Howdy, howdy. This is the ENT Maxillofacial portion tailored to the high yield emergency medicine shelf. So, with that being said, auricular hematomas often arise from wrestlers or boxers. The treatment is immediate drainage and prevention of reaccumulation of blood. You want to cover Pseudomonas with ciprofloxacin, and if it's left untreated, it can lead to something called cauliflower ear, which is an accumulation of fibrocartilage and overgrowth that occurs when an auricular hematoma is not fully drained. Tympanic membrane ruptures is a form of barotrauma leading to unequal pressures on either side of the membrane. High altitudes where the gas expands increase internal tympanic membrane pressure, whereas low altitudes like diving underwater, for example, increase external TM pressure. Can also occur from blunt penetrating trauma like a Q-tip in the ear canal. Noise, lightning, and infections can also cause tympanic membrane rupture. The treatment is most of these will heal spontaneously, but the patient should avoid getting into any form of water in the ear, whether that be swimming pool or other liquids into the ear. Otitis externa is inflammation in the external auditory canal. Risk factors include swimming, mechanical devices that can include things like AirPods, earbuds, hearing aids that occlude the canal. The most common pathogen is Pseudomonas. The treatment is ciprofloxacin plus steroids. Otitis media is characterized by otalgia and hearing loss. On physical exam, the most sensitive finding is impaired mobility of the tympanic membrane. Most specific finding is the bulging of the TM. The etiology is most common strep pneumo. And then mycoplasma infections can cause bullous meningitis, which is bullae on the tympanic membrane. Indications for antibiotics is if the child is greater than 6 months of age. And the most common complication is hearing loss. Mastoiditis can present with fever, posterior ear pain, and local erythema over the mastoid bone. The most common culprit is strep pneumonia. And then most common cause of chronic mastoiditis, on the other hand, is Pseudomonas. You want to get a CT if suspected mastoiditis, and the treatment is antibiotics and consult ears, nose, and throat specialists. Cholesteatoma is an abnormal growth of squamous epithelium in the middle ear and mastoid that can lead to conductive hearing loss. Most cases are unilateral, and most require surgical treatment. There's a very high reoccurrence rate of 50% will reoccur within 5 years of surgery. There are two camps of vertigo, central and peripheral, or two flavors, for example. Central will have a gradual onset, it will be constant, and then nystagmus can be purely vertical, horizontal, rotational, and it can persist with focus. Other central nervous system symptoms can be present as well, and this is contrasted with peripheral, which is often sudden, intermittent in duration, and without central nervous system symptoms. Central causes are broad and include multiple sclerosis, infections, central nervous system tumors, ischemia, and hemorrhage. Benign paroxysmal positional vertigo, or BPPV, produces vertigo symptoms that are worsened with head movements. Because it's a peripheral vertigo, the symptoms are sudden in onset, can be debilitating, and last a few seconds to minutes. It's due to canalolithiasis, which is calcium debris within the posterior semicircular canals that can form because of impaired endolymphatic flow due to clumped otoliths. The Dix-Hallpike maneuver is diagnostic. The Epley maneuver is therapeutic. Vestibular neuritis is often due to viral or post-viral inflammatory disorder, mostly affecting the vestibular nerve, which is due to balance, which can irritate a person's balance. It's rapid in onset, and it's severe. It's persistent vertigo, and it can have things like nausea, vomiting, and ataxia as well. The auditory function is preserved, and that's contrasted to labyrinthitis, which is a post-viral syndrome where the patient will complain of hearing loss, and that, on the other case, is self-limiting. Meniere's disease, you may see it appear as idiopathic endolymphatic hydrops. It's the triad of hearing loss, vertigo, and tinnitus. The first-line treatment is a low-salt diet. The next best treatment is thiazides. Acoustic neuromas, are also known as vestibular schwannomas, are slowly growing tumors in which the central nervous system has to compensate, leading to less significant symptoms of vertigo. And then cerebellar pontine angle tumors, include neuromas, meningiomas, and present with deafness, ataxia, and ipsilateral facial weakness. Sinusitis consists of symptoms of purulent nasal discharge, sinus tenderness, and maxillary or tooth tenderness. Mucormycosis is seen in diabetic patients with black nasal discharge, and you don't need imaging for sinusitis, but if it's more ominous signs are present like diplopia, periorbital edema, or altered mental status, you want to get a CT. Symptoms greater than 10 days warrant antibiotics, and complications include osteomyelitis of the frontal bone, meningitis, brain abscess, and cavernous sinus thrombosis. And nasal foreign body is often the culprit in pediatric patients with recurrent sinusitis. Anterior nosebleeds are localized to the Kesselbach's plexus, and posterior nosebleeds can result in significant hemorrhage, and most will need ENT consultation at admission. Posterior bleeds involve sphenopalatine branch. A broken nose requires ears, nose, and throat consult and closed reduction. Fluctuant masses inside the nose represent a septal hematoma. What you want to do is you want to remove the clot, pack it for 2 to 3 days, and refer to ears, nose, and throat for packing removal. There are 3 midface fracture classifications using Laffour classification. 1 and 2 can cause airway compromise, C-spine injury, cerebrospinal fluid rhinorrhea, and malocclusion. 1 involves the hard palate, 2 extends to the orbital floor, and 3 involves a zygoma and leads to craniofacial disruption. Salivary duct stones present as pain and swelling in the involved gland, oftentimes worse with eating. You diagnose via palpation of the floor of the mouth from the posterior to anterior parts of the mouth, and you're going to be hunting for a stone. Those that are in the submandibular region, the glands are often normally elastic, but in the setting of stones, they can be very tender to the patient. The best test is a non-contrast CT. And then submandibular glands in particular, or Wharton's duct, there are 4 risk factors for developing a stone here. 1 is dehydration, diuretics, anticholinergics, and or smoking. The treatment is hydration, and you want to discontinue use of anticholinergic medications such as Benadryl and amitriptyline, and then anti-staphylococcal antibiotics such as dicloxacillin or cephalexin are indicated. And then salivary is characterized by pain, swelling, and erythema in the area of the gland, and there's going to be pus draining from the duct. Suppurative salivary or bacterial in origin occurs in the absence of salivary. Typically affects the elderly, malnourished, or post-operative patients. It's basically a calculous cholecystitis of the mouth. There's no stones are present, but the patient's going to be very sick. Parotitis is inflammation of the parotid gland, which is the main salivary gland. Acute bacterial peritonitis most commonly caused by Staph aureus, and the most common viral cause is mumps. Extrapulmonary TB can affect the parotid gland as well, and then HIV can cause lymphadenopathy, which can also be localized to the enlarging parotid gland. The Centaur criteria is a set of criteria to help diagnose strep throat. You get 1 point for fever, sore throat without cough, anterior cervical lymphadenopathy, tonsillar exudate with the modified Centaur criteria, taking into account 3 to 14 years old. Add 1 point as well. 15 to 45, you get 0 points, and anyone greater than 45, you subtract 1 point. 4 points, you have a 55% likelihood of having strep. And then the rapid strep test is highly specific. The treatment consists of antibiotics to prevent developing rheumatic fever. Posterior chain cervical lymphadenopathy with sore throat and fatigue, you want to think about a monospot test for infectious mononucleosis. The most common etiology is Epstein-Barr virus, and then athletes must refrain from activity for a minimum of 21 days. The treatment is supportive. Ludwig's angina is a polymicrobial cellulitis of the submandibular space that often follows a tooth abscess. It's rare in children, and it's seen more commonly in those with poor dental hygiene. The treatment is airway management and broad-spectrum antibiotics. Esophageal candidiasis is an AIDS-defining illness. You diagnose via endoscopy, and not only should antivirals targeted for HIV be started or continued, the treatment should extend for 21 days with fluconazole. And then candida infections can be scraped off the tongue, whereas leukoplakia is a precancerous lesion that presents as white patches or plaques that is common in tobacco chewers, and it cannot be scraped off the tongue. Peritonsillar abscess often occurs in teenagers and young adults. The symptoms include trismus, hot potato voice, peritonsillar mass, displacing the soft palate, and uvula. It's polymicrobial infection, and you're going to need to use imaging. The most specific and sensitive test is going to be the CT with contrast. The treatment is incision and drainage. Retropharyngeal abscess is more common in infants and young children as opposed to adults. It's a polymicrobial infection as well, and the most common presentation is fever and sore throat. The exam will show posterior pharyngeal edema. You diagnose CT scan with IV contrast. The treatment is ears, nose, and throat. Consult for drainage and antibiotics. Diphtheria can be transmitted through respiratory droplets or skin lesions. It can present as a gray and or white exudate, creating a pseudomembrane formation in the mouth. Treatment is antibiotics and antitoxin in severe cases. Antibiotic choice is penicillin. Epiglottitis, the common etiology is H. flu B as the most common bug. The presentation consists of sore throat and dysphagia. Presentation is very similar to peritonsillar abscess without uvular deviation. The diagnosis, you're going to look on the plain film and you'll see the thumbprint sign on the lateral neck. The gold standard is visualization with nasopharyngeal oscopy. The treatment is you want to do your airway, breathing, and circulation, and then antibiotics. Ceftriaxone is the big one here. And then temporomandibular joint dislocations. Those are occurring when opening of the mouth is too wide. Most dislocations are anterior and bilateral, so they will often present with an open mouth. In cases of unilateral dislocation, the jaw is rotated toward the unaffected side. You want to use gloves and gauze. Place your thumbs on the back of the patient's molars and apply steady, slow traction downward and posterior. The mandibular fractures, on the other hand, are the most often occur at the mandibular condyle. Signs include malocclusion, trismus, and deviation of the chin. Positive tongue blade test warrants imaging, and if there is blood in the mouth, that means that it's an open fracture and the patient will need antibiotics. You diagnose with panoramic radiographs. And then if an adult tooth falls out, you need to place it back in. You're going to want to replant it as soon as possible. Rinse the tooth, if you can, in a pH balanced solution that preserves cells. It's called Hank's balanced solution. If that's not available, you want to use milk and or the patient's saliva. And that's it. That concludes this video. Thank you all for your time.